So I've been asked to give this talk in about 10 minutes ago. So John Philip, if you've never heard of the term winging it, or winging it badly, that's what it means in English. Okay. So I'm going to talk about probably a bit of a carry-on on from the last talk, actually, and it's going to be quite controversial, I think, hearing the comments. Using the frozen elephant trunk in acute type A dissection. I'm going to talk about the UK experience, which we managed to gather through the UK Aortic Surgery Forum. And I'm very thankful to my colleagues for submitting data to us. Initially, when we first started, we had data from Liverpool, Birmingham, ourselves, and Papworth. But within the forum, we were able to spread the message. And I think that I've captured about 95% of the cases that have been done using frozen elephant trunk in type A, acute type A dissection. Okay. So in type A, acute type A dissection, we talk about, in inverted commas, conservative surgery or more extensive repair. And it may not be an appropriate term to use, conservative surgery, but it's the best term that we could think of. Can we forward it? So in conservative surgery, I guess we're using the keep it simple strategy. You may have also heard terms like make sure the patient survive, live to fight another day, and things like that. And essentially, most of the time in the UK, for acute type of dissection, we're talking about putting an interposition graft in to keep the patient safe from rupturing into the pericardium, protecting the coronary ostium and things like that. If the tear goes into the arch, we may end up doing a hemi-arch replacement or total arch replacement. So not so conservative, but that's what we mean, all right? And in extensive repair, what we're talking about is irrespective of where the tear is in type A dissection, we're going to replace the whole of the ascending aorta, the arch, and then stent the descending thoracic aorta as our treatment strategy. So I'm talking about DeBakey type 1s in acute type A dissection, if we use the two terms. Not using it in the patients that have dissection strictly restricted to the ascending aorta. This is the tear going all the way around. And the data that we've managed to collect really relates to the Thoraflex device, which is manufactured by Vascotech here in this city, actually. Although a couple of the devices put in were from the Evita device, manufactured by the Jotech, now CryoLife, I think, in Germany. So essentially, we're talking about the Thoraflex device in this group of patients. So conservative surgery may be simpler, keeping it simple, live to fight another day, everybody can do it. But what are the disadvantages? Simple maybe, but still has, if you look at the published data, national published data, mortality rates of 20, 30%. But yet if you look at data coming from specialist centers, they'll quote mortality rates of 10, 15%. But in most countries, when you're talking about mortality for aortic dissection surgery, it comes in around about 20 to 30%. And the significant of the patients, number of the patients that survive, 60 to 70% of them, irrespective of how you do it, close anastomosis, which you've sometimes heard me argue about, open anastomosis, hemi-arch, total arch, 60 to 70% of them will come back with a patent false lumen. And a significant number of these patients will go on and develop aneurysmal formation of the descending thoracic aorta. And about 30 to 40%, although we just heard about 25% if you're in Hamburg, but the published data is that about 30 to 40% of patients will need some form of intervention at about 5 years. So for the patients that survive, there is potentially a problem not too far down the line. And the issue is, can we change that in some way? Can we change that by doing a more aggressive operation? What's the price that you have to pay to do that? Can we forward that? That's it. So to use a frozen nerve in acute dissection, I think when I first used it in the acute dissection setting, my thought wasn't really in preventing future complications of patients that survive. Actually, it was done because most of us who do acute dissection surgery, the problem comes from the distal anastomosis. That's where the bleeding comes from. And that's because there's patent false lumen, and you're stitching onto the adventitia, which invariably bleeds. And if you stitch that again and again, the bleeding becomes worse, the aorta around there becomes macerated, it becomes a big problem. So what we found was that by using the elephant trunk, by stenting the proximal descending thoracic aorta, by obliterating the false lumen, or perhaps just by depressurizing it, we actually help to protect the distal anastomosis in acute dissection arch surgery. And despite my initial thoughts of it being a longer, more complicated operation, leading to more instances of bleeding, that was not the case. So that was the main reason why I started using it. But actually, then, if you look at the stented portion of the descending thoracic aorta, there's no doubt there is a high rate of false lumen obliteration and thrombosis very early on after surgery. And the question is, does this lead to a reduction in aneurysmal formation in this group of patients? That is only a theoretical advantage at the moment. And of course, the third advantage is that once you have a stent in place in the proximal descending thoracic aorta, there is a very good landing zone for any TAAD procedures that you may want to perform in the future. Or indeed, you can use the stent to sew onto if you want to perform a conventional operation in that group of patients. Of course, the disadvantages are fairly obvious. It's a longer operation. It may increase the mortality and morbidity, and that's one of the reasons why that drove us to gather this data, the cost of to the patient of this operation. What's the price to pay? And of course, it's not a technique that's everybody would use in terms of dealing with patients in the middle of the night. And I think they're probably, the centers that I've shown are probably just the one or two people in those centers that will do it. So this is the sort of problem I'm talking to, sort of medium long-term complications of type aortic dissection. So you can see that in the left-hand side, there's acute hybrid dissection, and the patient survives the operation, and 3 to 4 years down the line, they come back with aneurysm of the distal arch, persistent false lumen, chronic dissection, and aneurysmal dilatation of the thoracic aorta. Not easy to operate on, actually. I think if you can do these with 2 to 3% mortality, that's great. But actually, this group of patients are usually not so great in terms of their general health. And the operation is quite challenging. And of course, if you're looking for a TAAD solution to the problem, it's difficult because you don't have a proximal landing zone. The anatomy is quite hostile to stenting. And so this is a patient that we did not too long ago. You can see acute type of dissection there, and you can just see the stented portion of the frozen elephant trunk. And you can see in the stented portion, there's been complete obliteration of the false lumen. True, there is a persistent false lumen distal to that, but for those of us who deal with chronic aneurysm, chronic dissection aneurysms, most of the dilatation actually comes in the first part of the descending thoracic aorta. That's the part of the aorta that dilates most aggressively. And even now, we're perhaps moving away from doing a full thoracoabdominal aneurysm operation to perhaps staging these operations by just doing the thoracic element and leaving a non-dilated or less dilated part of the abdominal aorta. All that is up for debate at the moment, all to do with improving organ protection, particularly spinal cord, and getting better results. But that's the result you get if you use a frozen elephant trunk in acute type A dissection. But what are the results? You know, it's possible. What's the cost? And the data that we have really just comes from specialist centers. In Europe, really just 2 centers. I'll be interested to know to find out what the French data is actually, Jean-Philippe. But these are 2 centers from Germany, one from Essen and the other one from Hanover. It's big operations. Perioperative mortality 11 and 8%. Paralysis 4% and 8%. Stroke 7 and 14%. And yet, and there are no data outside of what I would say super specialized centers. Can we forward the slide, please? Okay. So what we did was, as I said, we managed to gather the data from the UK, and all the units that I believe used the technique we sent them questionnaires, and they returned with the data over a 4-year period, and we looked at very simplified outcome measures. And this is the data that we have so far. So this was collected September, October, November time. At that stage, we got data from 66 patients. Fairly young age, so at the age of 62, you would expect that these patients will go on and run into problems with their distal aorta within their lifespan. The comorbidity and other factors are not too different from other published data on acute dissection. The stent that we use, the size of the stent, the stent comes in availability sizes from 24 to 40. Because of the dissection, we tend to size to the size of the aorta rather than oversize by 15 to 20%, which is what we would do in aneurysm patients. Other procedures performed as well at the time, not too different to other patients. Long operations, though. The bypass time is no doubt much longer, just under 6 hours on average. But yet with selective antegrade perfusion, we can do these operations with SAP time of just over an hour. So although long, difficult, very doable. So I guess what's the result? and I think halfway down the slide is what we should concentrate on. The mortality rate of this group of patients, early group of patients coming from 8 centres in the UK, is 12%, which is pretty good considering that the type of patients, the type of operations that done to them, and the overall published results regarding type A, acute type A dissection surgery in this country. Unlike the two centres that in Germany, in Essen and Hanover, we haven't as yet had any problems with paraplegia, but we have had a 17% rate of stroke or temporary neurological dysfunction. Long operation, long stays in ICU, short follow-up, but 86% of them are still going. The question is, will it lead to a reduction in complication rate and a reduction in interventional rate 5 to 10 years down the line? Thank you.